There it is. Good morning. I hope you've enjoyed the conference so far. By the looks of the folks last night, I know there's been some joy and enjoyment of this conference. We saw a lot of dancing and some beautiful displays of acrobatics last night. And we've got a great closing session before our last courses of 2017. Excuse me. And I'd like to start off the session with a presidential guest lecture. I'm sorry.
Okay.
Thank you. I was hoping my voice would hold out one more day. Mike Shevell is a pediatric neurologist who's presently both chairman of McGill's Department of Pediatrics and pediatrician-in-chief at the Montreal Children's Hospital. He received the annual Hauer Award of Child Neurology Society in 2014 for his substantial contributions to furthering our understanding of pediatric neurologic disorders through research, teaching, and clinical effort and administrative leadership. His career focus has been on neurodevelopmental disabilities, and we are very pleased to welcome Dr. Mike Shevell.
All right, thank you very much, Sarah. I'm going to dare not so greatly for the first time and actually walk away from a podium for a presentation. Hopefully I won't fall off the stage. I also need to point out, as a lifelong Montrealer, that I hope the audience realize that the Coliseum is not located in Montreal, but it's in Rome. I know some of you have probably been wondering, where is this wonderful arena? Anyway, can I have my slides on, please? So my job, and I don't quite remember how the topic came up, but my job is to describe the pediatric neurologist's role in the teen sport we call medicine, with particular reference to neurodevelopmental disabilities. And I'm going to start off by this oft-repeated African proverb: takes a village to raise a child. And I think what they mean is that the responsibility for the health and well-being of children is a collective, communal responsibility. I'm going to make one political comment and one only. This is a very historic city. We have witnessed the decline of not one, but two empires, first the French and then the British. And when historians write about the decline of the American empire, and it will happen as all empires decline in several hundred years, they're not going to talk about a president who has orange hair, but rather they will talk about the failure of the United States to ratify the Convention for the Rights of Children and the Convention for the Rights of People with Disabilities, and the failure to ensure that health care is not a privilege, but a right to all citizens and residents in a country. Can I sit down now? So we, and I'm referring to the people in this particular room, our focus is on a child. This child comes to us with certain challenges. And that child wants to be like every other child, just wants to do whatever he or she wants. And our job really is to help that child realize those aspirations. It really is as simple as that. But we need to remember that that child comes in the context of a family. Parents and siblings, and probably an extended family of grandparents and aunts and uncles and cousins. But surrounding that child is a community of health professionals helping that child. And all of these health professionals bring their own unique skill set, perspective, and professionalism. And I just listed the number of health professionals involved in the care of just one of the kids I follow in my cerebral palsy clinic. And I'm going to ask you, when your health profession is listed, simply to raise your hand and keep your hand raised until the end, and let's see how many of us are involved. There was an audiologist, there was a case manager, there was a developmental pediatrician, there was a dietitian, there was an educator, there was a family practitioner, there was a gastroenterologist, there was a geneticist, there was an internist, there was a neurologist, there was a neurosurgeon, there was a nurse, there was an occupational therapist, there was an ophthalmologist, there was an orthopedic surgeon, there was an otolaryngologist, there was a pediatrician, there was a physiotherapist, there was a psychiatrist, that one was for me, there was a psychologist, there was a physiatrist, there were researchers who helped us to get to that stage of knowledge, there was a social worker, and there was a speech-language pathologist. And I know I've forgotten people, but you know what? Everyone with your hands up, stand up. Have I made my point? And my apologies to any health professional who was omitted in that particular list. Your contribution is just as valid and important. If you ever played sports, you've heard your coach yell at you this: there is no letter I in the word team. I have a picture of Phil Jackson because he must have said this every day when he was coaching the Chicago Bulls in the 1990s. A collection of incredible talent, but mammoth egos. They only won because they played together as a team. But what Phil also said was that the strength of the team is each individual member, and the strength of each member is the team. Let me talk about my own personal medical discipline. Neurology is primarily a consultative, academic-situated practice. The focus has always been on chronic conditions for which there is yet no cure. When I walk by my surgical colleagues on my way to my outpatient clinic and they ask where I'm going, I'm saying I'm going to my neurology clinic, and I must be the worst physician in the world because I've never cured a patient in 25 years. Neurology retains an emphasis on the grassroots, the history and the physical examination, and I bet amongst all professional disciplines, we're the ones with the highest frequency of battered medical bags we still carry around on the wards and to the clinics. But we're also very technology intensive, a bit schizophrenic in a way. We're mechanistic. We rely heavily on electrodiagnostic testing, imaging, and increasingly in the last decade on precision medicine or molecular diagnosis. We're also becoming increasingly involved in rehabilitation and the social and psychological aspect of medical care. We are also shifting, and this really, I tell my residents, this is the best time to be training in neurology because we're witnessing a paradigm shift from a purely descriptive discipline to an interventional discipline. Think hypothermia in the asphyxiated newborn. Think IVIG. Think stroke teams and TPA in the adult milieu. I don't have to tell this audience what are the neurodevelopmental disabilities, but neurologists are implicated in all of these. And collectively, they account for about 5 to 10% of the pediatric population, an enormous care challenge for the medical and all health professions. I never tire of telling my residents, remember, there's a neuro in neurodevelopmental. And what I mean by that, all neurodevelopmental disorders are brain-based. You have to understand the brain first and foremost. What goes right, what goes wrong. But just as important as there's a neuro in neurodevelopmental, There's a developmental in neurodevelopmental. And what I try to convey by them with that statement is that our challenge is that these brain-based disabilities are occurring in the context of a brain that is maturing and evolving. And the challenges you see in a newborn are different from the challenges you see in a toddler, in a school-age child, an adolescent, or an adult. And I thought when I took on the challenge of this particular talk was that I think a developmental perspective applies in considering the role of the pediatric neurologist in the management of neurodevelopmental disabilities. And I'm going to take this developmental perspective as my guideline, as my roadmap in this particular talk. So what are the points of contribution that a child neurologist can offer in neurodevelopmental disabilities? We can offer something in prevention, prognostication, diagnosis and etiologic determination, treatment, whether it's symptom relief or the management of comorbidities, or in the transition to adult care. And I'd like to go through each of these in the remainder of my talk. For newborns at risk for later neurodevelopmental adversity, the neurologist is really situated in a very unique position as a treating physician and consultant. We really are a personal bridge between two very, very different worlds. We are there in the acute care units as an active consultant to the NICU. Some weeks when I'm on service, I might as well park myself on the 6th floor at my hospital, and I'm just bouncing from the NICU to the PICU doing consultation. And indeed, we have seen the emergence in the last few years of neonatal neurology teams, and the two that I think are really the paradigm of this is the one at UCSF and the one at the Hospital for Sick Children here in Canada. But we also provide care for these children in a chronic, long-term basis in our OPD clinic. And this is the paradigm we have here in Montreal, where we have long-standing now, almost 40-year-old neonatal neurology follow-up clinic, as well as subspecialty clinic directed at children with neurodevelopmental disabilities. So this involvement in chronic care gives us a personal, intimate knowledge of outcome, and it helps to inform and modifies, hopefully, acute practice in the NICU and provides evidence, personal evidence, to inform prediction and the inevitable limits to our certainty. And hopefully, this provides a practical and positive feedback loop in care. In terms of prevention, think of the paradigm shift of therapeutic hypothermia and term asphyxiated newborn, an area of particular interest for myself. Roughly anywhere between 10 to 20% of infants or children with CP will have a cause attributed in part or whole to intrapartum asphyxia. And as of yet, we really haven't defined the percentage of children with global developmental delay or intellectual developmental disorder or autistic spectrum disorders for which asphyxia is a potential cause. Neurologists can help in terms of the accurate diagnosis of asphyxia in the intensive care unit based on clinical features, laboratory investigation, and the early imaging studies. We are active participants in the monitoring that these children undergo during hypothermia with electrophysiologic monitoring, and we're active participants in the treatment of the concurrent seizures, both clinical and electrographic, that these children experience, which are known to impair outcome. And of course, there's been a shift as a result of our knowledge of outcomes away from the acute use of phenobarbital and benzodiazepines, which are known to impair cognitive development, toward more recent novel anticonvulsants like levetiracetam and topiramate. But there remain challenges when it comes to therapeutic hypothermia. And these challenges will be partially addressed by neurologists involved in studies. Should we cool passively pending the arrival of a transport team to a regional cooling center? What about the late preterm infants which has asphyxia? The infant that's above 32 or 34 weeks but not yet term? Should we start cooling beyond 6 hours after the asphyxial event? should there be a protective additive effect from other agents, such as erythropoietin, xenon, topiramate, and stem cells? And I will challenge this audience to say that we are really dropping the ball when it comes to intrapartum asphyxia, because 99% of worldwide newborn asphyxia occurs in low-resource settings. And indeed, 1 million children around the world die of intrapartum asphyxia on an annual basis. And fortunately, they don't die in Canada, the United States, Europe, or Australia, but they die in low-resource settings where the cost of cooling is simply prohibitive. We really should direct our effort both to improving maternal delivery as well as low-cost, low-technology cooling methods, such as the cooling pot I showed on this particular slide. And also in terms of prevention, prematurity and white matter injury is about 45% of cerebral palsy, about 20% of global developmental delay and intellectual developmental disorders, and an as yet unknown percentage of autistic spectrum disorders. Our neonatal colleagues, through better cardiorespiratory management, have improved things in terms of a marked reduction in cystic PVL. But where neurologists have helped is the outlining the maturation-dependent hypoxic ischemic vulnerability of oligodendroglial cells to acquired injury. And as an increasing knowledge of this pathway, a whole bunch of potential preventative agents have emerged and will hopefully come into practice in the next few years. The use of free radical inhibitors, free radical scavengers, blockers of AMPA such as topiramate, blockers of NMDA such as memantine, and also we have here starting soon in Canada a trial on metformin, an oral hypoglycemic agent, which promotes neurogenesis through activation of neural precursor cells. In terms of prognostication, this is where the neurologist puts on his black hat or looks into the crystal ball or uses the tarot cards. And there are medical populations at increased risk for later neurodevelopmental adversity. These populations include kids in the NICU that are premature, with IVH or post-hemorrhagic hydrocephalus, those children who are asphyxiated, those with defined genetic syndrome, or with congenital anomalies, with the big two being CNS anomalies and congenital cardiac heart disease. In addition, in the PICU, the populations at risk include children with traumatic brain injury, children with acquired infections such as meningitis and encephalitis, and children with catastrophic epilepsy. There's also an emerging population of fetuses who are being diagnosed antenatally, and on the basis of an identified CNS anomaly or genetic abnormality, we will be called upon to prognosticate. And I would dare to say that there will be an emergent subspecialty of fetal neurology in the very near future. In terms by prognostication, a lot of great work on outcomes have been done by many people sitting in this audience. The focus thus far has been on what can be measured or objectively diagnosed: ambulation, intelligence, behavior, epilepsy. But unfortunately, there's really limited information on what ultimately matters to the child and the family: activity and participation. And there's almost no information on the most important question that is related to quality of life, a question that I've been asked once in the NICU by a parent, and it moved my resident to tears and stopped me in my track and made me actually speechless, which my wife will say never happens. But basically, the most important question is, will my child be happy? At the present time, we have no way of answering this question in the NICU or in the PICU. Prognostication is limited by inherent and unavoidable uncertainty. You have to get comfortable with it if you're a neurologist, but is accurate most of the time in very general terms in saying, will this child have a typical developmental outcome or an atypical developmental outcome? The challenge in prognostication is extrapolating from the particular to the general, which is what you have in your outcome studies. There are remarkable inter-individual differences in plasticity and resiliency and the recovery from injury, which we have not yet gotten a handle on. There is always an exception to every rule. You learned here earlier this week about the emergence of epigenetic modifiers in terms of the expression of the genome and outcome. And of course, there are contextual environmental factors, the coping mechanism of a particular family, the community that family finds itself in terms of the barrier to participation and the access to services, and intrinsic factors that are related to the individual that we simply don't have a handle on immediately, such as motivation and the desire for mastery. I just want to highlight this particular study published in Developmental Medicine and Child Neurology earlier this year, led by Eric Racine, who may or may not be in the room right now. But this is a remarkable collaboration of ethicists, parents, neonatologists, and child neurologists. And the R-HOPE approach to prognostication is one that really should help guide us when we're having the prognostication discussion. The R stands for reflection. We need to be aware of our own individual values and those of the family, which in an increasingly multicultural milieu may actually conflict. We must have humility and awareness that we can be wrong because of the limitations of medical knowledge. We must be open-minded and aware of the influence of contextual factors and family values in shaping what is important and what are the eventual outcomes that are most important for the family. We must express partnership, that parental views and roles are valued and integrated into ongoing care decisions, and we have to be engaged. And by that I mean, no matter what the decisions are made, we must commit to provide continuity and inform parents of the transitions and challenges to care and make sure that they receive ongoing care, irregardless of the decision they make in the best interest of their child and their family. Prognostication, as you heard from the first plenary speaker, sometimes goes terribly wrong. And oftentimes it goes wrong because this is the first communication to parents that their child may eventually have a neurodevelopmental disability. Parents all expressed a hope for, and I put this in quotation marks, a normal child, even though we all know that there's no child completely normal. And with this loss of the potential of a normal child, there's grief and bereavement that the parents must go through. There is also, and I also put this in quotation marks, the burden of a chronic disorder, though many parents will tell you that they learn so much about themselves from having a child with a neurodevelopmental disability. But it does put stress on a family unit. And also there's an increasing medicalization of disability that is often a necessity because of the comorbidity these children frequently experience. However, prognostication does enable us to target what are invariably limited rehabilitation and interventional resources, hopefully to improve outcome. In terms of diagnosis and etiologic determination, community-derived referral for developmental delay are a common reason for consultation to child neurology. Why is my child not walking? Why is my child not talking? Why is my child not socializing? And the focus is really threefold from a child neurologist's perspective. Does this child have a neurodevelopmental disability? And if so, what type is it? We act because of our mechanistic training to determine if there's an underlying etiology is responsible based on the history and physical examination and pertinent, rationally chosen laboratory investigation based now on practice guidelines and diagnostic algorithms. And we've got to make sure that these children are referred for appropriate assessment and intervention services to the folk that I tell my residents really do the hard work, aside from the parent, the OT, the PT, the speech-language pathologist, the psychologist. I also like to I tell them a lot, obviously, and if I like to tell them that MD doesn't stand for medical doctor, it stands for medical detective, and that our role is to find out why that child has this particular problem. And this is captured in a great, very short quote from an anonymous parent that a good doctor is one who is curious. And the common trait I've noticed in all child neurologists is a remarkable degree of obsessive compulsiveness and curiosity. So what are these laboratory investigations? Very quickly, for global developmental delay and intellectual developmental disorder, there's the TIDE metabolic screen, which is basically designed to pick up 2/3 of almost 85 treatable disorders, an FMR1 or Fragile X, a microarray, and an imaging study. And I'm proud to have said that I was part of these diagnostic algorithm formulation, and they can be sought out in the literature and are all evidence-based. For autistic spectrum disorder, our diagnostic work up at the present time is more limited with the FMR1, microarray, and an EEG many neurologists will undertake. And for cerebral palsy, imaging at some point, and there's the whole debate about microarray being uniformly done in cerebral palsy. And I put up the practice parameter. It dates from 2004. It's clearly out of date. It needs to be revised, and I understand it is being revised by the guidelines committee as I speak. So current yield, we're getting better. Are we smarter? I don't really think we're smarter. I think the tools we have are better in terms of genetic testing and imaging. 60% of kids with global developmental delay will be found in etiology. 10 to 15% of autistic spectrum disorder, major challenge in that area. 85% of children with cerebral palsy. As I mentioned, this reflects the power of imaging and genetics, but wait, there's a tsunami about to hit every one of you in the audience, and that's the tsunami of whole exome sequencing and whole genome sequencing. The etiologic evaluation does not in any way supplement or replace the functional assessment, but rather complements it. Why do it? The end of a diagnostic odyssey. The question that the parent has about what and why. It limits further diagnostic testing. It frequently has genetic implications. It will help us in counseling the family regarding present and future implications of their particular diagnosis. It may call forth specific interventional needs, as well as the identification of medical and behavioral challenges that have ongoing implications. In terms of treatment, I think the neurologist has something to offer when it comes to movement disorders, comorbidities, as well as ameliorative and curative treatment options as well. In terms of treatment, movement disorder, this is spasticity. It takes place in the context of a team involving physiotherapy, OT, physiatry, developmental pediatric, neurosurgery, orthopedic, implicating a variety of different modalities, but individualized to a particular patient. We also can help with the very challenging dyskinesias, such as dystonia and chorioathetosis, and additional interventions are listed there with dopamine and dopamine antagonists, anticholinergic, and deep brain stimulation. Epilepsy is the bread and butter of child neurology. It's a frequent comorbidity of neurodevelopmental disability, with 30 to 50% of children with cerebral palsy having an epilepsy, 25% of children with autistic spectrum disorder, and 25% of children with a global developmental delay. Epilepsy in and of itself can be an etiology for a child's neurodevelopmental disability. Classic example, Dravet syndrome due to an SCN1A mutation. We all know, and it's been shown repeatedly, that controlling seizures optimizes developmental outcomes. However, you have to be very careful about what anti-epileptic drugs you choose to minimize additional toxicity. Many of these drugs have cognitive, behavioral, and sedating effects, and some of them are contraindicated with specific seizure types. The neurologist is often the gateway to very novel interventions, such as vagal nerve stimulators, the ketogenic diet, and surgical interventions, which all have a role to play in the management of epilepsy in children with neurodevelopmental disability. We also have the option now of ameliorative and, dare I say, curative treatment. One such example, congenital hemiplegia, and a demonstration by a Canadian colleague, Adam Curtin, that transcranial magnetic stimulation combined with constraint-induced movement therapy, had a synergistic improvement in functional hand use. This was done in school-age and older children, and we now have the baby champs randomized controlled trial looking at children under the age of 2 underway. And wait, remember that tsunami of genetic testing? Well, there's a tsunami of gene therapy that's on its way. And we're already starting to see the proof of principle in the beginning of the trend. Think of CRISPR and Cas9 genome editing, which basically can surgically snip out the defective part of a causal gene. And think of intrathecal nusinersen, which now had FDA and HPB approval here in Canada for spinal muscular atrophy. And I'll do a shout out to my colleague Maya Moskwy, who led the way for approval of this particular medicine in Canada. So this is really remarkable. This is part of the paradigm shift in child neurology. We also have a role to play in transition due to medical management of symptoms and comorbidities. We often follow a child with a neurodevelopmental disability over their entire pediatric life course. And our patients are reaching adulthood, and they're outgrowing our facilities, mandates, budgets, and competencies, dare I say. And what we must now actively engage in is the transition of patients and not their simple transfer. The child neurologist can act as a catalyst and facilitator for effective transition as they exit the pediatric care milieu. And this is a process that involves over time and involves the active engagement of the youth and their families to take into account expectation, self-management skills, competencies, etc. We also have to partner actively with our adult care providers for whom and have open communication with them. Child neurologists have addressed this issue. You can look at this consensus statement on our role in transition, which really could be extended to apply to a variety of different health professionals' role in transition. And I'd like to close by stating that as a child neurologist, you're especially privileged to be working with the most remarkable human organ, the organ that makes us human, the brain. And when subspecialists get together and we like to say, my organ is better than yours, or my organ is more important than yours, I always say to them, yeah, call me back when you can transplant a brain. Okay? Think about it. So, but we also must always remember that this brain is situated in this child, in this family, in this community. Thank you.
We have a couple of minutes for questions. Anybody have any questions for Dr. Shevell? Larry.
I can't hear. What's a question session without Mike Masal at the microphone?
Yeah. Mike usually has lots of questions. You mentioned Topamax and leveractam to replace phenobarb and Valium. Now, in adults or older children, Topamax can have significant, at least temporary cognitive impacts. The classic, one of my residents said his mother was using it for migraines and had to stop taking it because she was forgetting to pick up her kids. And so my question is, do we know for sure, and I don't know the physiology, that Topamax does not have any long-term adverse side effects?
No, we don't yet know for sure because it's probably been out and widely used for about 20 years now only. In my personal experience, that the drug that I most have to stop because of behavioral and cognitive issues in the older child is levetiracetam.
Right.
However, no drug has been more effective in controlling seizures in the last 20 years than levetiracetam. And if I had to be stuck on an island with 100 epileptic children and I needed only 2 drugs, levetiracetam, and probably an intravenous dilantin for the status epilepticus.
I hope that's never the case. Wow. Darcy, I'm going to take your question, and then we're going to have to be finished.
Okay, Michael, thanks for a fabulous overview of the importance of child neurology, and I couldn't agree more. My question is a dilemma that we may be facing as clinicians. So there's a big push towards early diagnosis and early intervention, which I think is really exciting and fabulous. And many of the children that have cerebral palsy are potentially in need of dampeners. So if you have a lot of dyskinesias or dystonia and you've got associated pain, we, query, should we dampen that? In contrast, if we do dampen it, we're sort of suppressing other brain activity. And as a child neurologist, are you wrestling with that dilemma, and what are your thoughts in terms of how we could move forward with what is best for the child?
Yeah, well, I think it all starts with, asking the child, if the child's able to answer that question, and asking the family, what are your particular goals? What do you want out? What do you want us to be able to help you do? And I'll quote, the famous Greek philosopher Aristotle, all things in moderation. And basically, this is part of the challenge and the beauty of dealing with brain-based disorders, is that it's never cookie cutter. And it has to be so individualized and particularized. And I think, that's the balance that we struggle with. And yes, I tell parents, whose children have significant seizure disorder, look, I can put you on 4 or 5 drugs and I can control those seizures, but that's not going to be a child you recognize or feel that you're getting love from or interaction from. So sometimes you just have to accept that there will be seizures or there will be an excessive amount of spasticity because you don't want to have that cost of excessive sedation or the loss of personal interaction.
Thanks.
Thank you. Thank you, Dr. Shevell. I appreciate it.
Thank you very much.
And now I'd like to invite our next panel up to the podium. And as Dr. Annette Manamer and Dr. Oskuli walk up, I'd like to thank them very much for their being part of our local host team. And so in appreciation for that, we have a small gift and another photo opportunity. So they're going to be moderating a very, very special Dr. Chambers, or the Chambers family lifespan lecture. This is a father's panel moderated by Dr. Manamer and Dr. Oskui.
So in this previous talk by Dr. Shevell, what was really emphasized is that at the center of the team is the child and family. And for those of you who had the privilege of attending the 2014 meeting, the Darcy Failings was president. There was a parent panel, and we had 4 amazing mothers share their honest reflections about the lessons they have learned with their child and family, and in terms of what was best for their child's health and well-being, and some of their experiences in the healthcare system. And I think most of you would agree, for those who were there, that this was an incredible experience, and really we walked away with some very important lessons learned. So we wanted to do a take two on this and get the dads' perspectives. And so Mariam and I found some really incredible fathers, mostly Mariam, I would say, and we spoke to them both individually and then as a group. And we asked them what they would want to share with this audience. And, this is a very academic audience of clinicians and researchers, and maybe intimidating, but what we explained is that this is a group that's very engaged and open and will really take the information to heart in terms of the meaningfulness of their honest reflections. So we had many discussions about what they would like to share, and really two things really emerged. There were really many issues around their experiences in the healthcare system and aspects of diagnosis as well, and also just their reflections on the lifespan and some of the concerns and some of the challenges and some of the successes. So we will just focus on some of these issues and hear from the dads themselves.
So it's my privilege to introduce the fathers on this panel today, and we'll maybe give them each a chance to introduce themselves, starting with Derrick Chung.
Hi, everybody. My name is Derrick Chung. I'm a math professor at John Abbott College, a magician, and recently started working with the Google Accelerated Science team doing research into neuromuscular diseases using artificial intelligence. And I'm here mostly as a father of a 5-year-old son with a very rare genetic disorder with CP-like symptoms.
Thanks, Derrick. Next is James Ferdinand.
Hi, everyone. My name is James Ferdinand. I work at Novartis in finance, and my wife, Linda, she also works in finance at a company called Starlight Children's Foundation. We're both chartered professional accountants. We have 3 kids. Keisha is 14, Trey is 12, and Trey's our son that has CP. He was born with congenital CMV. Then eventually, as time went along, he developed epilepsy. He has cortical visual impairment. He's nonverbal, and then recently diagnosed with inflammatory bowel disease. And our 3rd child is Kyrie. He's 8 years old.
That's great. Thanks, James.
Good morning. My name is Gavin. I'm, I think, here to indicate this truly is lifespan, and that I'm the old dad. And as is evident from the photograph, my wife, Tessie, here is holding our then infant son, Peter. Peter is now 31 years old. And the other picture there is Peter a few years back at his university graduation. I'm a recently retired college English teacher, and for 22 years I've been mostly volunteering to promote family-centered care, and very recently have been very involved with the Child Bright network in Canada, focusing on children with brain-based disabilities and their families.
So our first question to you all is relating to your interaction with health professionals. So what has it been for you as a father in this context of different healthcare experiences? And what advice would you want to give to people in this audience? So let's begin with Derrick.
Sure. So the first thing that I feel the need to say, though probably some of you know this already, is that my experience as a father is definitely different than the one that my wife gets as a mother, which to me is kind of a shame. Given, like, I have a slightly more flexible schedule than my wife, so I end up going to a lot of appointments with my son instead of her. And when we do get to appointments together, I don't want to really focus on the bad side, but since we're here, we might as well talk about them. There are times where we've gone to see specialists and they'll come talk to us, and I can think of at least a few occasions where the therapist never made eye contact with me at all. Every question was directed to my wife. Every answer was expected from my wife. And And I can understand that this, might be the role that, that is usually played out, but it certainly isn't the one in our family. And I can say from our end, it's pretty frustrating, because even when I have sometimes input to say, they will look at my wife and say, "Is that correct?" before accepting it as So yeah.
I don't.
And again, I don't want to say that that's everything's been bad experiences. We've had some great experiences for sure. I mean, there are therapists and there are doctors that have treated me wonderfully, that have understood that I do play a big role in helping to raise my son, as I think most parents try to be. But yeah, just so you guys are aware, I mean, fathers, you should pay attention to them as well.
So for myself, I tend to agree with Derrick. There have been times where, especially when my wife and I are both at the same appointments, that I do get, the doctors looking more at my wife. Dr. Shevell, just previously before his talk, he was making a joke about a lot of fathers bringing lists, from their wives to make sure we went through all the lists. So I just want to say, Dr. Shevell, that I think I've only brought a list maybe 10% of the time. And so that, as a father, 90% of the time I can get there with my own thoughts about how my son Trey is doing. And over time with the doctors, when they learn that I can actually converse about my child, they are now looking at me. And then when my wife and I are at the appointments, the tendency is that now the doctors are looking at both of us, because we do share different opinions about how our son is doing, and that's been our experience in general. Not all bad, it's been pretty positive.
I'm going to focus on the first of these questions about what it's been like being a father. And initially, our son had very obvious anxiety and deep obsessions and so forth. And where we were referred to a child mental health center, and the assumption was that there must be an attachment problem. Which parent is most guilty? Or maybe they're equally guilty or at fault in some way. And there were a lot of questions around our relationship to our own parents, like where is the origin of this problem? I think of my father, more as a father, I think of my father, who was an extremely exuberant, spontaneous, wonderful father who loved to sing. I'm getting married in the morning, you make me feel so young, the hills of Donegal. And the thing that my son cannot bear is me singing. He really, and it's something, so in many ways, and I think of my father as extraordinarily patient, and I have not been as patient with my son. So part of my experience is that my experience of being a father is so different. And I'm sad at that, because I always wanted to be like my father as a father. However, as time goes on, I think I'm see myself or trying to be more like my father. So I think sometimes, the good things the important things and the good things that we carry with us from people who may be long dead now are things also worth bringing up and talking about.
This is a good follow-up to Dr. Shevell's talk, the importance of diagnosis and etiology. So how important was it for you to obtain first-aid diagnosis for your son, and then possibly to identify a cause for it? And what should we know about this from your experience, Derrick?
I mean, for us, it's important. That much is clear. You always want to know, like, if there's something wrong or different with your kid, you want to know what it is. You want to know the nature of the problem. And, particularly from a science background, my wife's from a science background, I mean, you want that knowledge. So for us, it took kind of a long time. We went through all these paths. As I mentioned kind of in the intro, our son has a very rare genetic disorder. In fact, as far as we know, there are only 4 other known cases in the literature. So, so it took quite a while to get to this answer. And the answer that we have is kind of woefully incomplete because, I mean, what do we have to go on? Like for a long-term prognosis, we have 4 other children, all kind of rather young as well, because I guess this kind of genetic testing is more recent. And even in then, there's kind of this huge variability. So I know some people said, like, well, you didn't really get an answer at all. But I kind of beg to differ. I mean, would we have liked something where we had really an encompassing theory of what was going to happen and what to expect? I mean, absolutely. I mean, we would love to be able to plan for everything in our child's life, but I mean, even with normal kids, you can't do that. But just having some sort of answer, if nothing else, it kind of like shoot away all the people who are like, your kid is that. I know what your kid has. Like, I've seen kids like this all the time. And it's something that we've run into, I mean, both just in just our lives in public, as well as sometimes with some therapists as well who treat our kid a certain way because they're sure. And I've had, a few therapists, some not even occupational PT therapists, just say, well, I'll treat your kid this way because I know what he has. And, with that kind of attitude, because it's like, I've seen plenty of kids, I know exactly what he has. So it's kind of frustrating. As Dr. Shevell was saying, I mean, even kids with the same diagnosis are different. So, but for us, that diagnosis is kind of key because it helped us at least understand what he has. I mean, there isn't much we can do in terms of kind of figuring out the future, but we can go with therapy, and there at least is a part of our mind that's like, okay, we know what it is, we know what it's not, and we can kind of, I'm just going to say this, my wife has some people in her family who are doctors and they're the most annoying ones that say, we know what your son has. So it's kind of nice to say, no, you don't, you're wrong, leave us alone. And this was actually partly why I got involved in kind of research in neuromuscular diseases. I know nothing about the medical background. I'm a math, computer science guy, but somehow it just got me interested in all this kind of stuff. So I think people have to realize, I mean, I know a lot of therapists, you're like, it's all about the therapy, but for us, like, just having knowledge, even if it's not really concrete, is kind of soothing in some sense.
For myself and my wife, it was actually really important for us to know what the diagnosis was because we knew probably after 20-something weeks that during the pregnancy that there was a problem with Trey's brain. We had to wait for him to be born in order to find out what it was. And I remember when the doctors, it was actually good, there was 3 or 4 doctors that came in and said, we know what your son has congenital CMV. And the first thing I said was, are you sure? And they looked at me a little bewildered, and I know it. The reason why it was hard is because I just wanted to really make sure that they were really, really sure. And that started the next step of myself and my wife doing research. We're not doctors, we're finance people. But we ended up finding some clinical studies, and we started reading up on the effects of CMV on our child. And because we're numbers people, we saw percentages and stuff inside the clinical studies, and then we was like, okay, tick mark, as time went by, Trey has this, or so you went from like, I don't remember all the stats, but with the CMV, let's say the 1% and then the 90% of the 1%, Trey always had that, so that he suffered the most, I guess, from having the CMV. But knowing that we had done a bit of research, we were able to go back to the doctors and have a really good conversation with them and discuss what to do next. The big unknown for us obviously was identifying the cause, and obviously it's very difficult for CMV to really isolate how Trey got it. But the interest for us is to find out, again, what do we do next and what's to come. And the what's to come for me, I know it's question one, but hardest part for me personally is what Trey is getting progressively worse, but I guess slowly. So the issue is with all these diagnoses that we keep getting is, how do we handle this next hurdle? And so every time he gets a new diagnosis, again, we're, doing the research and talking to the healthcare practitioners. Really, I believe it's really important to get as much information as we can from you guys, the experts, on what the condition is and what we can do. I've always appreciated the options that the healthcare practitioners have given us in order to make a decision as to how we should best treat Trey. Listening is a very important, it's very important to have as a healthcare practitioner, and I encourage all the healthcare practitioners to continue to listen to the moms, yes, and as well as the fathers, and as well give your advice thinking that it's not just a patient, it's a person, and my son's name is Trey. I've noticed that the doctors that have been really, really effective with the care of my son are the ones that actually took the time to sit down, the ones that actually looked us in the eyes instead of in the corner, and the ones that really showed empathy for what we're going through. Obviously, being in our shoes is very, very difficult for those that don't have a child with special needs. But it does help us get through the situation that we're having, or crisis that we're having with our son, when we know that the healthcare practitioner is thinking of our son. Again, not the patient, but our son, Trey. Like, the patients have names. That's what I'm basically trying to admit.
As I mentioned, for us, the road to diagnosis was a long one. So that initially there was a notion that there was some, I gather, problem of attachment, and this was a long time ago. This was, I guess, close to 30 years ago. So many of you will understand that environment. And actually, one of the healthier things we did was we actually stopped the therapeutic sessions that we were having, the family therapy. It was the best thing we could do. And then our son had some other health problems. He had kidney problems, respiratory problems. He was, at one point, diagnosed with generalized anxiety disorder. But problems continued. His obsessions deepened. There was a teacher who said, "Is he happy?" The only person, we never had a healthcare professional ask that question. His situation became more difficult. He also began, my wife said when he was in kindergarten, "I think he's depressed." And he's been depressed since then as well. But when he was 12, things were getting harder, so we went back and we saw a child psychiatrist who met with us a few times, and at one point I was the only, my wife wasn't at this appointment, and she took down from behind her a book, and she opened it, and she presented to me, and she said, "What do you think?" And it was DSM-4, and that was a description of Asperger's syndrome. And I said, I read it with wonder, and I thought, that sounds about right. It was a good match. And I think the way she did that made a certain kind of conversation easier. So we had a conversation, and the word autistic was used a lot. And I remember coming back from that appointment, Peter was with me, and we were walking down the hallways of the hospital, and Peter was very vehement. "I am not artistic." So for him, being artistic would be the worst thing. So, but actually, but actually to be called artistic. But for each of us, that was different. For my wife, she could look around at her own family and probably then identify 5 of the 7 people in her immediate family as being on the spectrum, not including her. She grew up surrounded by men who were hand choppers when they would talking at you all the time. So for her, that diagnosis presented a whole new series of questions. For Peter, it's been a long process. For a long time, he was pretended to be indifferent to the diagnosis, and he's become more interested in it over time. And I certainly have, I went out and, like Derrick and James, found out all I could about it. I just inhaled the information. So we each reacted differently. But I would say this, the world cares about the diagnosis. Grandparents, other extended family, teachers, neighbors, parents of other children. In terms of, I have had lots of parents, friends who actually want their child to have that diagnosis because it means their child is interesting, quirky, bright, intelligent, etc. And so the world keeps coming to us with questions about it, assertions and so forth. And there are many things that people who want that diagnosis don't have, but we've had to live with it. And it has been good to have it. It's been necessary to have it. But it does present its own opportunities and challenges.
So our final question relates to the lifespan and some of the concerns that we had talked about together on the phone that you are experiencing through each stage of development and some of the ways that you're addressing these challenges. Maybe we'll start with Frank first and work on the other way.
I think with transitions in particular, I think there's a lot of focus, and Michael was talking about the transition from pediatric care to adult care, and that's certainly very important. But I remember going to a meeting after we got this diagnosis, and I said Peter was around 12 years old at the time, so we went to a center in Toronto for autism called the Geneva Center. And at this center, we met all kinds of other parents, most of whose children were much younger. And what was fascinating was they were all concerned about the future. Will my child be able to hold a job? Will my child be able to have a partner, be in an intimate relationship, be a parent? And certainly, even at that point, what will happen when we get sick or have weaker health, or eventually when we die? And so I think what's important is, we think of transitions in the child's development, but there are transitions in the family, deaths of grandparents, families who transition from energy to burnout, families that transition in their configuration. And these have profound implications. This is part of the child's transition. So with Peter, we notice whenever we have a medical appointment, my wife or me, it is really deeply concerning to him because we know he's terrified of when we're not there. And this is something we have to think about. So we have to talk a little bit more about the future in some ways and about being as specific as we can and knowing what that right balance is. And one of the most valuable things we heard from a health professional was a developmental pediatrician who told us a couple of things that in all these transitions have been helpful. First of all, she said, you can anticipate at the very minimum to have 10 or 15 years more than most parents of active parenting. So when your son is 25 or 30, she would never use the word his son, and I take James's point, when Peter is 25 or 30 or perhaps older, you're going to have to be involved in many ways in the way parents of adolescents are. And that's proven to be largely true. So to help us anticipate. But she said a couple other things. She said, many people would want to say, well, look at all his skills. They would want to minimize it. She said, you have actually a very difficult situation, which was actually one of the most helpful things anyone ever said, because she recognized it. Everyone else wants to reassure you. And we found her acknowledgement of the difficulties we were having actually reassuring and empowering. And she also said, that you're doing a good job. You're doing really well. And I can't tell you the number of times when we have been feeling that we have very much failed. When remembering that she said that having gotten to know us and having gotten to know Peter. Because in the midst of all these failures and difficulties, that's something that helps us through difficult transitions. And that was said 16, 17 years ago.
That's good. So when we were transitioning, it's like what Frank was saying, there's just a lot of different ways to look at it. So I guess structurally, if I were to look at Trey going from not being in school, we used to call daycare school, so daycare before actually starting kindergarten, we had stresses about, will somebody be able to take care of him like we're taking care of him? And we got through that, getting him into a daycare, but we had to go through 2 actually before we got the one that was right for Trey. Then when we had to transition Trey to the next school, so let's call it the elementary school, but he's not in actually a grade. We had stresses there too, because we went to the different schools, and again we were saying, well, is this the right environment for Trey? How would we feel him going there, and will he be happy? And then another trend, and he's doing well in school. So they're small milestones for some people, but for us they're large milestones. Even though Trey's nonverbal, we've been very fortunate that he can actually show us he's happy. And I know that's not every parent can say that, but we can get him to smile. He does have things he doesn't like, and he will get upset, he'll stick out his tongue, or he'll scream, but we're really happy, and that's made it easier for us as we go from one transition to another, and it's even helped even the healthcare practitioners and also the teachers that Trey can show that he's happy. So that's a big thing for us. In terms of dealing with, let's call it the transition from one diagnosis to another diagnosis and one drug to another drug, that's hard. I mean, as a father, I don't know if my wife thinks about it, but I think he's on 5 or 6 medications now. One of them, Dr. Shevell mentioned, that was concerning to me because he said there might be an issue when he gets older. We all know that we're at risk of having some type of adverse reaction to a drug, but my son takes these drugs every single day. And my hope is that the drug dosage doesn't get to a point where he completely changes, that he can still show how he communicates either with his eyes, or he can use switches, a yes to the left or right with a no, or just by him smiling. So he can show, we want him to keep doing that. See, so again, these small little things, I guess you could say looking from the outside are big for us, but we want him to still be capable of doing that, whatever comes his way, whatever comes our way. We have 3 children, and that's also a big, it's a big transition in the family as well for us. Everything does go slower, just going to the mall or going to somebody's house. That everything does take its time. And so we're also concerned about the transition of Trey's health and the impact even on our kids. And we want to make sure our kids grow up well too, like normal kids. Again, normal kids. But they're in fact not normal because not 100% of the children around the world have a special needs child. But I know they're going to be extra special because of that, and I know that's the message that they'll spread to all of their other friends as they go along in life. In terms of addressing the challenges, talking about it in this forum is actually pretty helpful. I was actually more nervous driving here in the car, but it's kind of weird, but I actually feel comfortable amongst all the healthcare practitioners because there's so much in the hospital system all the time. So just talking about it helps. So talking with my wife helps. Talking to the social worker, occupational therapist, physiotherapists. I mean, all of you guys, there was that picture before with the child and everybody around. It's weird when you look at that one thing. You all have a part in a child's development and in the impact that it has on the family. All of you. So, and the transition. The last thing I'll mention, transition for me of concern is now going from, well, what will happen when Trey goes 18, because now he's 12. Like, I'm always thinking so far in the future, will he get the same care as an adult? That's really scary for me as a child. Like right now, I think Trey gets exceptional help from the doctors, and again, physiotherapists, occupational therapists, all the types of therapists as a child. And I know that emotionally, a child is a little more stronger to some than thinking of an adult. But I do have to say that that child is still somebody's son or daughter. So don't forget that I'll just leave it there.
So Frank and James said basically a lot of the things that I would agree with. I do just want to add a couple things to this. Every transition is hard. Any of you are parents, you realize that to get your kid ready for school, like my son is 5, Xavier is 5, and getting him to school is kind of a big deal. But with a special needs kid, it's a much bigger deal in terms of finding a place that he can go, a place that will be happy, organizing therapies. It's just that much extra. And because we don't have a long-term prognosis, we have to think about what happens 40 years from now when maybe we're not around and our son will still need care. So, I mean, I'm thinking, when we say lifespan, I have to think, probably much further than parents with normal kids who, like, you figure by the time you get the kid out of your house, you're fine. And we may never be able to do that. So it's just, this is big uncertainty. So we address it, but I try to plan as much as I can. I try to learn as much as I can. Coming to a place like this, being able to talk to you guys is helpful. Like I said, I mean, because of my son's diagnosis, now I do research in neuromuscular diseases. The more I know and the more I can kind of, figure out about this, I guess the better I feel. But yeah, that's about it.
Thank you. So we have a few minutes left. So I'd like to ask each of you maybe 1 or 2 sentences on what would you like the audience to reflect on as they leave the conference now today and head back to work next week? Maybe starting with Derrick.
So, I mean, I just hope you guys listen to what we have to say, right? I mean, a lot of this stuff, when we talked earlier about dealing with fathers or just like diagnoses, assumptions are something that we all kind of make. And, assumptions, if we don't make assumptions, nothing happens, but we should always just kind of keep them in check and understand that every kid is different, every situation is different, and give everybody kind of just time to, hear what they have to say.
Yeah, I echo the same thing. Big thing for us is listening. That's been really helpful from the healthcare practitioners, and to be sure to always be thinking about the name of the patient and to try to name. So again, my son Trey. That definitely has been helpful because then I do realize that you guys are really thinking of my son.
I would certainly recommend being open to the recognition of paradox. When Peter was younger, he was a terrific runner, but he had terrible mechanics. His running coaches would say, I don't understand how he can be so fast, because, you know, I guess this is typical. So I think he needed help with the mechanics, but he also needed people who could recognize that he was fast, and maybe there was something about his uniqueness that made him fast. So that sometimes things that are strengths. So Peter has terrific cognitive skills. He has he has great cognitive skills in many areas. But his great cognitive skills are also a point of great vulnerability. They are, in some cases, a weakness. So at one point, he found a job after he graduated, and he was promoted into an area where his weakness was exposed. And what happened then was a kind of disaster. I know I'm going over my couple of sentences, but he came home one day. He said to me the morning, he said, "Dad, what time are you leaving for work today?" Because my schedule varied. So I said, "I think I'm leaving at around 9:30. He said, "Fine." But I wound up leaving it a little bit later. And it was in the middle of a very, very cold winter day in Toronto. Temperature about -27 Celsius. Still cold. And I looked up from my basement window, and in between the recycling bin and the garbage bin was a huddled figure trying to take some shelter from the cold. And so now I realized it's my son. And what happened was he went into work, and he lost the job. He was fired because he was promoted for the wrong thing. But he was so ashamed of having lost the job that he was hoping I wouldn't be home. So strengths can be weaknesses or vulnerabilities, and sometimes what seems to be weaknesses, like his great honesty, his inability to pretend to be interested in things he's not interested in, can also be strengths.
So Mariam and I are hoping that you'll really reflect on some of these really important and meaningful words as you leave the conference today, and hopefully some of it really resonates with what you do as you move forward. We may have some time for questions. So please join me in thanking these amazing dads to sharing their personal reflections.
While they're doing the photo, and I'm just wondering if Jill and Hank, do you guys want to come on up here to do the photos with these guys? And then as they do that, Mark Joswiak and Bernard, Dan, will you guys just come up and get ready to make your announcements without getting into the photo? You first.
Ladies and gentlemen, on behalf of the awards committee, I am honored to announce the Best Scientific Poster Award for 2017. The award is going to Alex Pagnozzi and co-authors from Brisbane, Australia, for the poster titled Measuring Neuroplasticity in Cerebral Palsy, What Cohort Size Are Needed for MR Imaging? And I would like also to announce that the best demonstration poster for 2017 is going to Merlin Wright and co-authors from Hamilton, Ontario, Canada, for the demonstration poster titled Scootering for Children in Use is More Than Fun, an appealing approach to improve function and fitness.
Hello, it's a great pleasure and honor to announce the prize for the best poster for the most promising career award. But while I have the microphone for Mickey's and your hearts are beating, I want to announce that since the beginning of the year, all the abstracts for all the articles in the journal are available in Portuguese and Spanish, and I want to thank the Latin American Academy for this. Now, to end the suspense, the name of the award winner for this most promising career award is Dr. Rachel Thompson for her work on hip status and the long-term functional outcome in myelomeningocele. Well done, Rachel.
That's great. Okay. Thank you to all of you who voted for the Life Shots photo contest. And I'd like to announce the 2017 Life Shots photo contest winner and winners. The contest is sponsored by the Weinberg Family Cerebral Palsy Center in at Columbia University. In first place, we have Sweet Summer, Sweet Life. Oh. In second place, the flowers smell even sweeter when I'm on my whizzy bike. Or whizzy bug. I don't know if we have that one. And then the third place was Dreaming in Color. So all winners receive an electronic tablet and a professionally mounted version of their photo displayed here on site. Thanks to all of you for submitting. We had many, many submissions this year. It was so very difficult, wasn't it, to pick the winner. So I want to thank you all who have made the 71st annual meeting a huge success. We're already looking forward to the 72nd annual meeting. And we want to invite the 2018 planning team, Gilda Vargas Adams, Leslie Weird, and Kristen Pierce up here to fill you in on the details.
Cincinnati, actually hear that song at Cincinnati Reds games. They are unlikely to be playing still next year in October. I wanted to start just by thanking Sarah, Susan, and Jacques for what has to be the best AACPDM so far. But also, just to let you know how excited we are to welcome the Academy to what has been my home city for over 20 years. I'm not sure that I can vouch for weather as fabulous as we have had here in Montreal, but I can promise you that Cincinnati has great food, fascinating history, and that bridge is actually there in real life. So we're looking forward to welcoming all of you on a transformative journey, and these are my tremendous scientific program co-chairs, Leslie and Kristen.
Thank you. We're looking forward to a fabulous meeting next year, and I really just want to encourage everyone to fill out evaluations, comments. We are going to take everything into consideration. We certainly value everyone's opinion. So the more you have input, the better we can make the meeting. We certainly have a very tough act to follow, so we look forward to next year.
And we're very much looking forward to receiving your abstracts so that we can learn about all the new and exciting work that you're doing. The call for submissions will come out shortly after this meeting and will close at the regular time at the end of January. So we'd love to see you all in Cincinnati. Thank you.
We have a short video which is not quite as cheesy as the song. We'll see you all there.